recurrent disease which characterize alternating periods of exacerbation and periods of remission, and which are going to manifestation of stages of the formation of the defect, and defect I mean the ulcer in the wall of the stomach, or in the wall of duodenum, or in the wall of the stomach and duodenum also. Recurrent disease characterized changing alternating periods of exacerbation and remission, and the main characteristic that all this problem leading to development defect or ulcer in the wall of the stomach or and in the wall of the duodenum. Etiology and pathogenesis. According by the last concept, the pathogenesis of ulcer is in general reduced and in the moment of development imbalance between the factor of acid peptic aggression or aggressive factors of the gastric contents and protective elements or protective factors of the mucous membrane of the stomach and duodenum. So pathogenesis, it's a disbalance by the action of the host factors, which leading to positive part in the aggression factors. Aggressive ulcer formation includes an increase in the mass of parietal cells, and often it's associated with heredity, and hyperproduction of gastrin, and dilation of the nervous system and humoral regulation of gastric acid secretion. Increased production of the pepsinogen and pepsin, which impaired gastroduodenal motility, delay or conversely acceleration of evacuation of the stomach, seeding of the gastric mucosa by Helicobacter pylori and special bacteria like Helicobacter pylori. And the reduction of the protective properties of the mucous membrane of the stomach and duodenum can occur as a result of a decrease in the production and dilation of the qualitative composition of the gastric mucus, and gastric mucus, it's a protective mechanism, and a decrease in the secretion of bicarbonates, which combined with protection layer in the stomach and ulcer, and the decrease in the regenerative activity of the epithelial cells of the lower of the stomach and duodenum, and the dilatation in the blood supply to the gastric mucosa. In fact, also decreasing level of blood supply and taking a part in the pathogenesis of peptic ulcer. Decrease in the content of prostaglandins in the wall of the stomach, for example, with taking non-steroidal anti-inflammatory drugs, and we knew with you already that the main effect after taking non-steroidal anti-inflammatory drugs, it's reducing synthesizing of prostaglandins and blockage inflammatory reaction. This is a role in the development of ulcer is currently assigned with the Helicobacter pylori, which was discovered in 1983 by Australian scientists Marshall and Warren. And in fact, in modern concept, we can divide it with you two etiologies way of stomach ulcers and duodenum, which associated with Helicobacter and which not associated with Helicobacter. The spectrum of adverse effect of Helicobacter pylori on the gastric mucosa and the duodenum is quite diverse, and these bacteria produce such a number of enzymes, urease, protease, phospholipase, which in the local level go into the damage of the protective barrier of the mucous membrane, as well as various cytotoxins. In fact, it's some pool of these enzymes which lead into local damaging mucosal layer. Helicobacter pylori promotes the release in the gastric mucosa of interleukins, lysosomal enzymes, tumor necrosis factor, aggregation factor, which cause the development of inflammatory process in the gastric mucosa. First of all, producing enzymes. After that, second point in the pathogenesis, a release of the gastric mucosa interleukins, lysosomal enzymes, all factors of aggregation, which lead into the local inflammatory process in the gastric mucosa. Seeding of the gastric mucosa of Helicobacter pylori is accompanied by the development of superficial enteral gastrines and duodenitis and leads to an increase in gastrines level with a subsequent enhancement of hydrochloric acid secretion. And the presence of Helicobacter pylori leading again to development disbalance between protective and aggressive factors through the mechanism of change in secretion of hydrochloric acid. An excess of hydrochloric acid, which entering the duodenal lumen under condition of the relative deficit of the pancreatic bicarbonates, contributes to the progression of duodenitis and in addition cause the appearance of gastric metaplasia in the duodenum. And metaplasia, as we discussed with you, it's replacing the epithelium of the duodenal mucosa by the gastric type. And in fact, metaplasia is a whole term which we can characterize change in the type of the epithelium in all types of in all parts of gastrointestinal tract. In the future, especially in the presence of additional etiological factors, it's a background. Before it, we discussed with you background for ability of development ulcer defect. In the future, especially in the presence of some additional etiological factors, heredity predisposition for what we need to take in anamnesis, first blood type, smoking, neurophysic stress, psycho-emotional stress, ulcerative defect forms in the metabolized mucosa in the place of local inflammation, chronic damaging leading to metaplasia, and exact its point for development ulcerative defect. About 80% of duodenal ulcers and 60% of stomach ulcers are associated with Helicobacter pylori. Helicobacter pylori negative ulcers are most often caused by medication of non-steroidal anti-inflammatory drugs, also can be caused by systemically using glucocorticosteroid. It depends from the way of taking glucocorticosteroids. It can be oral, it can be intravenous type. So our scheme about pathogenesis. Look, Helicobacter pylori, gram-negative, root of bacteria, mechanism established, special enzymes which producing stimulated leukotrienes on the local tumor aggregation factor, which go into development local inflammation, which leading to inhibit detection of hydrochloric acid in antrum and which leading to other secretion of hydrochloric acid in the stomach with the stomach juice. Take a non-steroidal anti-inflammatory drugs. Look, in the reason and the cause, just a minute, in the cause of peptic ulcer disease, we can separate it three groups: Helicobacter pylori, medication, which include non-steroid anti-inflammatory drugs, which leading to inhibition COX-1 from COX-1 to COX-2, and it's leading to inhibition prostaglandins. Leading to increasing production of hydrochloric acid. Acetylsalicylic acid plus minus other antiplatelet agents like clopidogrel. Acetylsalicylic acid, it's an indication of the coronary heart disease medicine, and sure we need to assess the taking of this medicine because this medicine can aggravate the situation with peptic ulcer. Mucosal COX-1, decrease in prostaglandins, and some direct erosions action on the mucosal of the stomach and duodenum. And the small another group, it's other disease. Ischemia, as we discussed with you in the first slide, that decrease in blood supply can be in a result of the reason of development peptic ulcer. Stress, Zollinger-Ellison syndrome, it's a tumor which located more often in the head of the pancreas, which producing gastrin, and it's a gastrinoma. Gastrin leading to stimulation produced by periatal cells hydrochloric acid. Cancer, and adenocarcinoma, Crohn's disease, and lymphoma. Some immunological status which can, and after taking glucocorticosteroids like medication and treatment, the base treatment of this condition can be associated with development peptic ulcer. Imbalance. Look in the center of the slide. Imbalance between gastroprotective factors and aggressive factors. Decreasing gastroprotective factors. Which one? Mucose, barrier between the cells and hydrochloric acid. Changing of mucose due to ischemia, maybe. Blood flow removes hydro ions, supports mucosal cells. Epithelial cells, physical barrier, bicarbonate buffer. Prostaglandins, hydro ion secretion, mucose production. And aggravation of aggressive factors, acid, gastrin, histamine, acetylcholine promote acid secretion in parietal cells of the stomach, and any types of toxins. Drugs, and first place it's non-steroidal anti-inflammatory drug, directly toxic to gastric epithelial cells, drugs that reduce platelet and adhesion and plaquing. So, this disbalance going to develop an erosion of mucosa. Erosion can make a wall in the blood vessels or can reside in the blood vessel, and in this case we can assess with your two way bleeding into stomach and bleeding into esophagus. It depends on the localization of the ulcer defect. Bleeding into the stomach, blood pass through gastrointestinal tract, contact with hydrochloric acid and oxidized by hydrochloric acid and digestion, and melena, it's a dark, terry, full smelling stool or black color stool. It's a main sign of any internal bleeding. We upper part of gastrointestinal tract cause oxidized by the hydrochloric acid. Next, blood gets oxidized by hydrochloric acid, but moves back up through the esophagus, and it will be caused ground emesis. Also, contact with hydrochloric acid in the context of the stomach, but it's going not with normal motility, going out, and it will be like vomiting with the caused ground contents. Bleeding can go into the vessel of the esophagus, and it will be hematemesis or vomiting blood. Red color, bright red color, vomiting. Also, development of the erosion of mucosal going to irritation of somatic innervation of the stomach and duodenum located in the thoracic vertebra 5, 6, 7, and 8. It's leading to development pain syndrome and dyspeptic syndrome, or dyspeptic and epigastrical pain, and development nausea due to stimulation center of nausea and vomiting. Look, pay attention that in elderly patient, it's a more than 80, and patient on non-steroidal anti-inflammatory drugs, mucosal erosion can be silent or asymptomatic. It's very dangerous. Look again, assess the host factor. For risk factor which can go in aggravated situation with peptic ulcer: smoking, it's a drinking alcohol regularity, it's a dryness, it's a aggravated ability of developing ulcer, it's a have a family history of ulcers, and have some other serious disease, for example, liver failure, kidney failure, or lung disease which go into polyorgan failure and insufficiency, have untreated psycho-emotional stress, eating spicy food, and the age more than 50 and above. Unfortunately, aging we can assess like a host factor for development peptic ulcer. Epidemiology. It's known that from 11th till 14th of men and age till 11th of women during their life can get peptic ulcer. In the United States, for example, 500,000 patients with newly diagnosed ulcer and more than 4 million patients with relapse of the disease. And peptic ulcer with localization in the duodenum is 4 times more common than ulcer with localization in the stomach. Among patients with duodenal ulcers, men predominant, other women, there is among patients with localization ulcer in the stomach, the ratio of the men and women is approximately the same. In recent years, there has been a downward trend in hospitalization of patients with uncomplicated forms of ulcer called the rot. In the same time, an increased frequency has been observed all over the world complication of ulcers like a bleeding, like a perforation, which is due to the growing intake and aggravated of the taking non-steroidal anti-inflammatory drugs without any control. There is a downward trend in the number of patients with complicated forms of the course of peptic ulcer, largely due to the effect of modern regimens of anti-ulcer therapy and increase in the availability of endoscopic diagnosis and then the active use of the screening test to clarify the presence of Helicobacter pylori. Classification peptic ulcer. First of all, international classification of disease with a codage: acute with bleeding, acute with perforation, acute with bleeding and perforation, acute with bleeding and perforation without, chronic or unspecified with bleeding, chronic or unspecified with perforation, chronic or unspecified with bleeding and perforation. Next. Depends from the presence or absence of Helicobacter pylori, ulcer which is associated with Helicobacter pylori and not associated with Helicobacter pylori. Also, there are independent disease like essential peptic ulcer, like essential arterial hypertension, which we discussed with you, and symptomatic ulcer of the stomach and duodenum. Medicinal, stressful, with endocrine pathology, with other chronic disease of internal organs, and the last stage and stage of decompensation, it will be stressful or aggravation of peptic ulcer. Also, we can classify, independent of the localization of gastric ulcers, cardiac and subcardial, lower, stomach, antrum, pyloric channel. Depending on the localization, duodenal ulcers, bulbs, post-bulbar, combined stomach and duodenal ulcers. In fact, in general, we can classify by the localization of ulcers. Ulcers can be located on the small and large curvature of the anterior and posterior walls of the stomach and duodenum. We can classify according by the number of ulcerative lesions, single and multiply. Also, we can classify ulcer depending on the size of exactly this ulcer defect. Small, up to 1/2 centimeter in diameter, medium, 10 to 2 centimeters, large, between 2 and 3 centimeters in diameter, and gigantic, more than 3 centimeters in diameters. The diagnosis indicates the stage of the disease: exacerbation, scarring, which we can confirm endoscopically, stage in the red and white scarring, stage of remission, exciting symmetrical and ulcerative deformity of the stomach and duodenum. During formulating the diagnosis, the presence of complications of ulcers, including anesthetic, is indicated, like a bleeding, like a perforation, like a penetration, like a development pyloric stenosis, and the nature of surgery intervention if it was about this complication. For example, gastroplastic by the Byrate 1 or Byrate 2. It's also dates from the anamnesis of the patient, and it shows us the condition of the patient. Symptoms and signs of stomach ulcers: pain in upper epigastrical region, or dyspeptic syndrome, as we discussed, indigestion, loss of appetite, and try to keep yourself patient from the taking of meal, cause pain contact with the taking of meal, nausea, bloating, Development heartburns, and heartburn also can be signs of peptic ulcer, not only gastroesophageal reflux disease. Blood and vomiting in case of development complication like bleeding, and it will be hematemesis, and in case of complication, discoloration of the stool. So pain and some characteristic of pain syndrome. The leading symptom of exacerbation of ulcer is pain in the epigastrical region, which can radiate to the left half of the chest and left shoulder blade, chest, or lumbar spine. Some similar irradiation with the coronary pain. But pain occurs immediately after eating with ulcer of the cardiac and subcardial section of the stomach. Half an hour or an hour after eating in case of localization of ulcer in the body of the stomach. With ulcers of the pyloric channel and duodenal valve, significantly late pain, 2 or 3 hours after eating, or some hungry pains that occur on empty stomach and pass after eating, and also night pain and aggravation. Night pain are usually observed for localization of the stomach ulcers in the pyloric channel. Pain occurs after taking anti-secretory and antacid drugs. We can use it like a test. So pain, epigastrical region, and we can classify pain for immediately or early pains, localization in the cardiac or subcardial section, pains between half an hour or 30 minutes and 1 hour, localization in the stomach, and with localization closer to pyloric channel, it's a hungry pain and night aggravation of the pain, which go in and pass after the taking a meal. Belching, like a sign of peptic ulcer. With exacerbation of ulcer, belching is acidic, nausea, and constipation are also commonly signs of peptic ulcer. Vomiting of acidic gastric contents can be, which brings relief, and therefore caused by patient artificially, and it was always considered like a sign of ulcer. However, at present, it's relatively rare. Weight loss. With an exacerbation of the disease, weight loss of the patient is often noted, and very rare you can find the patient with primary peptic or essential peptic ulcer with the high body mass index. Also, it will be pain with asthenic type of condition. Because despite the preserved and sometimes even increased appetite, patients limit themselves in the amount of the food, in timing of the food, and which are leading to gradation and development pain syndrome. Clinical symptoms observed with exacerbation of peptic ulcer disease are not pathognomic and can occur in other diseases. And unfortunately, the disease of ulcer must necessarily be confirmed by other research methods. Because is this dyspeptic syndrome absolutely non-specific for only peptic ulcer? Typical signs for peptic ulcer are seasonal, spring and fall periods of exacerbation and increased pain in developing dyspeptic symptoms. In uncompleted cases, ulcers usually proceed with alternating periods of exacerbation lasting from 3, 4 to 6 and 8 weeks, and remission lasting from several weeks until many years. And we need to continue our treatment going to the period of remission closer to a year or many years. But peptic ulcer, it's a difficult diagnosis and also dangerous of complication of peptic ulcer. And under the influence of unfavorable factors, for example, such as physical strain, psycho-emotional stress, chronic, taking non-steroidal anti-inflammatory drugs, or drugs which leading to reducing blood coagulation, acetylsalicylic acid aggregation, but also increasing ability of the bleed, anticoagulation. In case of alcohol abuse, complication can be provoked and can develop. Which complication include bleeding, perforation and penetration of ulcers, the formation of scar ulcer, stenosis of the pylorus, and malignancy of an ulcer. First of all, bleeding. Peptic ulcer bleeding is observed in 15–80% of patients with ulcer, more often with the localization of ulcers in the stomach, and risk factors for its occurrence are acetylsalicylic acid and non-steroidal anti-inflammatory drug, Helicobacter pylori infection, and ulcer size more than 1 centimeter. Look, it's not a gigant, it's not a large size, it's only middle size of ulcer, but it's already host factor which increases the ability of developing bleeding. Ulcerative bleeding is manifested by vomiting of coffee grounds, like a hematemesis, or black tarry stool with melena, sign of internal bleeding. Hematemesis after contact with hydrochloric acid and going out through the esophagus. Black tarry stool or melena after contact with and oxidizing with the Helicobacter or hydrochloric acid and going with the normal motility. With massive bleeding and low secretion of hydrochloric acid, as well as the localization of ulcers in the cardiac section of the stomach and vomit, and impurity may be noted unchanged blood. In the upper part, you can find in upper part of the stomach, which go into the gastroesophageal reflux disease, closer relationship, you can determine really bright color and not unchanged blood. Sometimes common complaints like a weakness, loss of consciousness, lowering blood pressure appears in the first place in the clinical picture of ulcerative bleeding tachycardia, and it will be sign of cardiogenic shock, or not hypovolemic shock, due to losing the volume of articulated blood. And also with melena can appear only after a few hours. We need to wait in this normal motility. Next, perforation. Perforation of an ulcer occurs in 5–15% of patients with ulcer, more often in men. Physical stress, alcohol intake, and overeating are predisposed to its development, and sometimes perforation occurs suddenly against the background of an asymptomatic or silent course of the ulcers, which we discussed in elderly patient, in patient in the reanimation medical ward without any clinical signs. In case of taking glucocorticosteroids, also to the asymptomatic ulcers. Perforation of an ulcer is clinically manifested by acute or major pain in pit of the stomach and the development of the collapsoid state. And when examining a patient, plain-like muscle tension of the anterior abdominal wall like a sign of peritonitis, and sharp pain on palpation of the abdomen, and a positive symptom of Schottky-Blumberg, like the main clinical symptom in the surgery, the positive and the symptom of involvement in the inflammation process, peritoneum cover. In the future, sometimes after a period of imaginary improvement, the picture of spiraled peritonitis. In fact, perforation, it's a part of surgery intervention. It's a surgery we need to make in a surgery consultation. It's more surgery pathology like a therapist. Penetration. Another term, penetration means the penetration of the stomach of duodenal ulcer into the surrounding tissue or neighbor organs, pancreas, small amentum, gallbladder, and common bile duct. With penetration of the ulcer, persistent pain arises that lost the previous connection with food intake. Body temperature rises, blood tests are detected, increase in erythrocyte sedimentation rate, and the presence of ulcer penetration is confirmed radiographically and endoscopically. Where is difference between perforation and penetration? Look at this picture. Perforation, then the contents of the stomach going out from the chamber of the stomach and go inside the abdominal cavity, going to peritonitis. Penetration, it's absolutely the same hole in the wall of the stomach, but which closed by any neighbor organs. So the contents of the stomach cannot go outside. Perforation outside, penetration, closing without going outside. Next complication, pyloric stenosis. Pyloric stenosis usually forms after scarring of ulcers located in pyloric channel in the initial part of the duodenum, and often development, this complication contributes to the appearation of suturing performed ulcers in this area. The most characteristic clinical symptoms of pyloric stenosis are vomiting of food which are eaten the day before. Then your patient will tell you about such signs that had a vomiting of food which had eaten in the day before. You absolutely should think about pyloric stenosis, as well as belching with the smell of hydrogen sulfate and long time staying in food inside the stomach. During palpation of the abdomen in the epigastrical region, you can determine the late splashy noise or positive Vasilenko symptoms. You can be detected in thin patient, gastric motility, and sometimes visible detectable. With the compensated pyloric stenosis, exhaustion of patient can progress and electrolyte disturbance join. So pyloric stenosis, esophagus, normally motility, stomach, headache, fundus, pyloric channel, duodenum, pyloric stenosis, which blockage normally way of the contents, normally way of the food from the stomach to the duodenum and going to staining this food in the duodenum or in the stomach. Next complication, malignancy. Malignancy of the benign gastric ulcer is not a common complication as previously thought, but for malignancy, ulcers are often mistaken case of timely unrecognized ulcerative cancer except the stomach, and diagnosis of the malignant ulcers is not always easy. Clinically, sometimes it's possible to note a change in the nature of the cause of ulcer with the loss of periodically and seasonality exacerbation. It will be absolutely the same level of exacerbation due 1 year. In blood test, we can determine whether your enemy, like a sign of any localization tumor process, only specific. An increase in erythrocyte sedimentation rate can be detectable. Finally, the conclusion is made only by the histological or morphological examination of biopsy samples, which taken from various plots of ulcers. And there are some special rules for taking biopsy, not less than 5 points, and in the center, around of ulcer dated and from the center of ulcer. Some part about symptomatic ulcers, primary or essential peptic ulcers and symptomatic ulcers. Stressful gastroduodenal ulcers include acute, usually multiplying, damaging, not only single, it multiplying many ulcers. Stomach and duodenal ulcers that occur with common burns, curling ulcers. After craniocerebral injuries and neurochirurgical operation, cushioning ulcers, and after extensive cavity operation, large surgery intervention, especially those related to organ transplantation. In acute myocardial infection, it can be concomitant disease. In patients with end-stage chronic renal and hepatic insufficiency and other critical conditions. Symptomatic ulcers are usually acute, multiply, often occur, they are asymptomatic, and characterized by a tendency to gastrointestinal and are characterized by high mortality, often due to the several causes of the background disease. Among the medicinal ulcers of the stomach and duodenum, acute erosive and ulcerative lesion, which are associated of non-steroidal anti-inflammatory drugs for gastropathy, which working for the blockage COX-1 enzyme responsible for the synthesis of prostaglandins, is the wall of the stomach are of the greatest importance. And gastroduodenal ulcers occur in 20-25% of patients taking non-steroidal anti-inflammatory drugs for a long time, erosive lesion in more than 50% of patients. These factors for developing symptomatic ulcers include elderly patients, a history of ulcer, concomitant disease of the cardiovascular system and liver, a high dosage and non-controlled taking non-steroidal anti-inflammatory drugs, and the simultaneous use of anticoagulants, non-steroidal anti-inflammatory drugs, and acetylsalicylic. Gastroduodenal ulcer and erosion due to non-steroidal anti-inflammatory drugs are also often multiplying in the nature and often have a low symptoms and manifestate sudden from the gastrointestinal bleeding and checked or vomiting with coffee grounds or black cherry stew. So, diagnosis of a peptic ulcer. Surely the diagnosis of peptic ulcer established on the basis of anamnestic dates and taken right way compliance and medical history of the patient, characteristic compliant detection of peptic ulcers before maybe your patient already knew about it. On the dates of physician examination, detection of soreness and resistance of the muscle of the abdominal wall during palpation, some pain in the epigastrical region, in the palpation of pyloric channel in the zone above the stomach. Instrumental examination and detection of the peptic ulcer, endoscopic and radiological examination of the stomach and duodenum. 3 points. Laboratory diagnostic tests in order to exclude enemy like a result of high ulcerative bleeding or result of tumor growth. All patients with ulcer disease are recommended to perform a general blood test to determine the level of hemoglobin, hematocrit, red blood cells. A clinical blood test for uncompleted ulcer more often remains without any significant changes, but enemy may also can be detected and indicating some obvious and latent bleeding. In all patients with ulcer, in order to exclude high ulcerative bleeding, we need to take in stool analysis for occurred blood. A certain place in the diagnosis of exacerbation of ulcer is occupied by the analysis of fecus for occurred blood. When interpreting the result of this test, it should be remembered that a positive reaction of fecus to occurred blood is also found, and in many other diseases which requires their mandatory exclusion. And look, pay your attention that if your patient taken iron medication for thyroid deficiency anemia, the analysis of the stool analysis of the occurred blood will be non-informative because presence iron in the gastrointestinal tract will show you already positive reaction. Instrumental diagnosis of peptic ulcer. Esophagogastroduodenoscopy, fibrogastroduodenoscopy, recommended absolutely for all patients with suspected ulcer in the absence of contraindication in order to confirm the diagnosis. Look, about the main contraindication in case of peptic ulcers, if you already knew about perforation. Perforation is a contraindication for esophagoduodenoscopy. An endoscopic examination confirms the presence of the peptic ulcer, clarifies its location, depth, shape, size, allows you to assess the condition of the bottom and edges of the ulcer to identify concomitant changes in the mucous membrane and gastroduodenal motility disorders. It's a picture from our previous semester, methodic of fibrogastroduodenoscopy, esophagogastroduodenoscopy, flexible tube which going from the oral cavity to esophagus. Surely it's usually simultaneous examining of esophagus, stomach, and duodenum, absolutely around it with visual control under the light and with ability of the taken biopsy. And it's a picture, look, different stages, white scarring, ulceration without any regeneration, with the localization of an ulcer in the stomach, a biopsy is performed with subsequent histological examination, which eliminates the malignant nature of the ulcer. And the main purpose for fibrogastroduodenoscopy surely is contour of the treatment of the patient, not earlier than during 1 month, but its alternative diagnosis and the taken morphological study for assess malignancy of the ulcer. Next, second point in instrumental diagnostics, it's radiography of the stomach and duodenum is recommended for patients who suspected ulcer who cannot perform an endoscopic examination in order to confirm the diagnosis. Surely it's not the first line, but it can be. An X-ray examination reveals a direct sign of ulcer, a filling defect on the contour or in the relief of the mucous membrane, an indirect sign of the disease, local circular spasm of muscle fibers on the opposite wall of the stomach in the form of a pointing finger, some convergence of the fold of the mucous membrane to defect, cicatricial and ulcerative deformity of the stomach and duodenal valve, fasting hypersecretion, gastroduodenal motility disorders. So, feeling defects and pointing finger. And look, firstly for him, feeling defect, look, we're assessing contour of the small curvature and find some additional. It's a feeling defect, and exactly on the opposite side, due to convergence folds, it's a local spasm like a pointed finger, and this pointed finger shows us direction to localization defect of feeling. It's as him, look to X-ray, pointed finger, big large one, pointed finger, and look there, small defect of feeling. Another picture, pointed finger, big, large, defect of feeling in the small curvature, but more vertical position of stomach. Defect of feeling, pointed top. Horizontal position in case of obesity, maybe, or in case of hypersthenic. Pointed finger, defect of feeling. X-ray examination with the aim of diagnosis ulcer is not used as often as before, and it's used in case where there's some reason, for example, the presence of contraindication, it's not possible to conduct an endoscopic examination, when for the purpose of differential diagnosis with the infiltrative ulcerative form of cancer, and it's necessary to evaluate the motility of the stomach wall, and when it's necessary to assess the nature of the evacuation from the stomach and assess the time and the nature of evacuation. Patient with suspected ulcer perforation, in order to confirm, it's recommended to conduct to the computer tomography of the abdominal organs, and in case with positive Schottky-Bloomberg tendency to aggravate the condition of anterior abdominal wall, it's absolutely condition for computer tomography of the abdominal organs. This method allows you to determine the presence of free additional gas in the abdominal cavity, the volume and nature of this effusion, to localize abnormalities, including to determine localization perforation. In patients with suspected perforation or penetration of an ulcer, but in case when the CT scan is not possible to do, in order to diagnose this complication, it's recommended to perform an ultrasound scan or an other view radiograph of the abdominal organs, only in case that you haven't ability to take a CT scan. A long diagnostic research may lead to a dilatation and condition of the patient, worsening condition of the patient till the hypovolemic shock, and subsequent unfavorable prognosis, and only in the absence of CT scan in the medical clinic, it's possible to perform ultrasound and abdominal radiography to diagnose ulcer perforation. Other diagnostic methods. In order to determine indication for eradication therapy in case of peptic ulcer which is associated with Helicobacter pylori, all patients with peptic ulcers are recommended to make a test for the presence of Helicobacter pylori infection. Better prefer using a respiratory urease test or determination of Helicobacter pylori antigen in the fecus. Also, it's a simple, and with the simultaneous endoscopy using a quick urease test. We can do it simultaneous during fibrogastric esophagus, stomach, and in the same time taking quick urease test. Respiratory urease test and determination of Helicobacter pylori antigen in the fecus are the most optimal tests for the initial diagnosis of Helicobacter pylori infection. Surely you can take biopsy materials and go into the multicultural studying of the Helicobacter pylori, but you needed more time for cultivated Helicobacter. Quick urease test, very simple, and also it's a gold standard. It's a methodic. Patient drinks a solution of 13th carbon enriched urea, natural non-radioactive substance that breaks down compound to 13th carbon dioxide, and after 30 minutes later the patient exhales intake collection back, and it's sent to manufacture for analysis, or exactly it can analyze by the source, by the special device in the back, and you can assess the presence or not presence. Cause look by the picture, presence of Helicobacter pylori, its ability of Helicobacter pylori disturbing the urea for carbodioxide and ammiac, and you can assess the presence of it. In patients undergoing endoscopy at the same time, when a quick urease test can be the primary diagnostic method. When using endoscopic diagnostic methods, Helicobacter pylori take at least 2 biopsy samples from the stomach and 1 biopsy sample from the antrum. And a serological method for detecting antibodies for Helicobacter pylori also can be used for the initial diagnosis of Helicobacter pylori infection. However, only if the antibodies determined are of the immunoglobulin G class. In such type of patient with a refractory course of peptic ulcer, in order to exclude the Zollinger-Ellison syndrome, recommended to determine the level of serum of gastrin in the blood, and the pathogenesis of gastroduodenal ulcers in Zollinger-Ellison syndrome is associated with severe hypersecretion of hydrochloric acid, like a result of the presence of the gastric production tumor in patients which more often located in the head of the pancreas. And these ulcers are usually multiplied, localized not only in the stomach, about the so high level of hydrochloric acid, which go with the contrast in the duodenum, in the ileum, but also in the ileum, and sometimes due to regurgitation in the esophagus, which precede the severe pain and persistent diarrhea. For Zollinger-Ellison syndrome, significantly multiplying damaging of the mucosa, stomach, duodenum, and ileum. When examining such patients, a sharply increased level of gastric acid excretion is noted, especially in the basal condition. An increased content of the serum gastrin is determined 3-4 times compared with the norm, and in recognition of Zollinger-Ellison syndrome, provocative tests with secretin and glucagon, ultrasound and CT scan of the pancreas will help to establish this diagnosis. Look about pathognomic of Zollinger-Ellison syndrome. Unlike typical peptic ulcers, not on the stomach and duodenum, also go into ileum. Gastrinomas most commonly occur with the triangle and located in this triangle, outlined by the hepatic portal vein, neck and body of the pancreas, look, and later 2/3 of the duodenum and hypersecreted gastrin, causing to debilitating recalcitrant and acid reflux. Also, it's a pathological scheme of Zollinger-Ellison syndrome, localization in the pancreas, production of gastrin observed, and leading to stimulation of the parietal cells to development, to producing hydrochloric acid, and it's really critical level of hydrochloric acids, leading to aggravation to the side of aggressive factors, leading to development ulcers. But ulcers with localization not only the stomach, not only the duodenum, but through the all width of the gastroesophageal tract, and exactly can regurgitate it in the esophagus.